Good morning, everyone. A warm welcome to all of you for the second day of SPEEDCON. And we have two interesting sessions lined up for the first segment on adrenal insufficiency and male infertility. And to chair this session, may I now invite the senior physician, Dr. Suresh Mittal, Dr. Sailesh Sahai, Dr. Deepak Kothari, Dr. Nityanand. Over to the chairs for the further conduction of the session.
Good morning, everybody. Good morning, everybody. I welcome you all for the second day, the first session, and we have two speakers, and there are two important topics. One is adrenal insufficiency and second is male infertility, and the speakers are Dr. Gagan, Priya and Dr. Jay Chaudia. May I invite the first speaker, please?
Good morning, everybody, and thanks to the esteemed chairpersons for inviting me here. Congratulations to SPEED for conducting this physical program. It's been a really successful one, and it's after a hiatus of, I think, 2 years that we're meeting in person. The vibes are as usual as good. So what I'll talk of in the next few minutes is the patient in focus. That means approach to a patient with adrenal insufficiency. Now, what basically is adrenal insufficiency? It is an inadequate production of the hormones secreted by adrenal cortex. So predominantly the deficiency is of glucocorticoids, but we can have the secretion of other hormones may be affected as well. Now, if you look at adrenal cortex, it has three major layers which secrete mineralocorticoids. Then we have glucocorticoids and adrenal androgens like DHEA. Now, what is important to remember, glucocorticoid and adrenal androgens are under the positive stimulation from ACTH from the pituitary, while mineralocorticoid secretion is not predominantly affected by ACTH. There may be a small contribution, but it is a part of the renin-angiotensin-aldosterone system. Glucocorticoids control metabolism, both glucose, lipid, and protein metabolism, but they are traditionally classically known as the fight or flight response regulating hormones. So in acute stress, this is what triggers the fight or flight response. In addition, they have anti-inflammatory properties and immunomodulatory properties. Mineralocorticoids regulate salt and water homeostasis and are also involved in the regulation of blood pressure. What about the androgens? The adrenal androgens, we do know that they have a role in adrenarche or pubarche, so the appearance of axillary and pubic hairs. In women, they may have some physiological roles in the maintenance of libido as an important source of the androgens, but in men, we don't really know much of their role. Now, when adrenal insufficiency happens, the defect can lie in the level of the adrenal gland, what we call as primary adrenal insufficiency. Or the defect can lie at the level of the pituitary, that means reduced secretion of ACTH, or at the hypothalamus starting from CRH, reduced secretion of CRH. Why I'm highlighting this is because in primary adrenal insufficiency, when the cortex is directly involved, the secretion of all three hormones would be disturbed. So you have low cortisol, low aldosterone, and low adrenal androgens. But in secondary and tertiary adrenal insufficiency, the mineralocorticoid axis is spared. It is under control of renin-angiotensin-aldosterone system and not under control of ACTH. Now, what are the commonest causes of adrenal insufficiency? If we look at primary adrenal insufficiency, world over, the commonest cause is autoimmune adrenalitis. It can be isolated, or it can be a part of autoimmune polyglandular syndromes, APS. But in India still, one important cause is infections like tuberculosis or disseminated fungal infections. So we have seen patients with coccidioidomycosis, histoplasmosis, and all of those varieties coming with primary adrenal insufficiency. There can also be infiltrative disorders like sarcoid and others, or lymphomas. Infarction and hemorrhage in an acute setting can be a cause, tumors, metastasis, or somebody who's undergone a bilateral endolectomy for some reason. Genetic causes predominantly in the pediatric age group include the congenital adrenal hyperplasia. More common than primary AI in clinical practice is secondary AI, which can result from tumors of the pituitary gland. There can also be hypophysitis or infection, infiltration of the pituitary area or radiation, etc. And the most common cause of adrenal insufficiency we will encounter in clinical practice is, any pointers? The commonest cause, it is not these two, it is tertiary, resulting from exogenous glucocorticoids. So when we use glucocorticoids for a period of longer than 3 to 4 weeks, they can cause suppression of the HPA axis, and it can lead to atrophy of the adrenal glands and tertiary adrenal insufficiency. Other causes, the same kind of disorders which can cause secondary AI can also cause tertiary AI, and even the high dose opioids can suppress the adrenal axis. So when to suspect adrenal insufficiency? It can be a potentially life-threatening condition, but the clinical presentation when you should suspect is patients presenting with anorexia, nausea, vomiting, or abdominal discomfort, patients having lethargy, fatigue, or malaise, or weight loss, and then in primary adrenal insufficiency, because of the mineralocorticoid deficiency, there can be distinct salt craving, postural drop in blood pressure. So patients complain of postural giddiness, and you look at the BP, there is a significant postural drop. There can be muscle cramps resulting from hyponatremia, and then lab anomalies like you pick up hyponatremia or hyperkalemia in a lab report, think adrenal insufficiency. Primary AI also can have features because of the high ACTH secretion in primary AI. So when cortisol will fall, the negative feedback to pituitary is lost and ACTH secretion is increased, and this can lead to hyperpigmentation, like especially of the skin creases, buccal and gingival mucosa. So look inside the mouth of the patient, of extensor surfaces of elbows and knuckles, and also on scars. So if you have too dense pigmentation in these areas, again think of this cause. Secondary AI might be more difficult to discern, but there will be features of other pituitary hormone deficits, and usually it will not have aldosterone deficiency. So salt craving and those features may not be present. Electrolyte disturbances may be subtle. You might see a low sodium somewhere, but not other things. Then in women, because adrenal androgen secretion is lost, loss of axillary and pubic hair can also be one of the features we can look for. In people with diabetes, if you encounter hypoglycemia on a previously stable anti-diabetic regimen, again you must suspect things like hypothyroidism, adrenal insufficiency, hypopituitarism. So think of these. So let's look at a case scenario. A 21-year lady comes to the emergency room with persistent vomiting history since 7 days, abdominal discomfort, loose stools, and drowsiness since morning. There is no fever, dysuria, or respiratory symptoms. So what this looks like is some GI disturbance going on. In the past history, there is history of recurrent vomiting, loss of appetite since 1 month, and malaise and weight loss also since 1 month. 1 month ago, she'd seen a gastroenterologist, undergone an upper GI endoscopy. There was some mild gastritis, and she was started on PPIs and prokinetics. Past history, the only significant finding is she's a known case of hypothyroidism, and she's doing well on 100 micrograms. So what was done in this case? She was lean, she had dehydration, she was drowsy, there was tachycardia and hypotension and a mild abdominal tenderness. Thinking again of an acute gastrointestinal problem going on, saline was started, ultrasound abdomen came out normal, the abdominal X-ray came out normal. The labs were sent and the supportive management was started. Typical in the labs is pre-renal azotemia, hyponatremia, and some degree of hyperkalemia. So what are we thinking now? What happened after 3 hours with this fluid management and supportive care? While her BP improved, there was no improvement in her sensorium. And by that time, her TFT report had come in with a past history of hypothyroidism. It will be a routine practice to send that. TSH being high and endoconsult was sent. What was found on examination again, this patient had vitiligo, small patches of vitiligo, and she had buccal and mucosal hyperpigmentation. So what do we have at our hand? What should be our clinical suspicion next? Anyone from the hall? What we have is a lady, young lady, with symptoms which could suggest adrenal insufficiency, and what she could be in is acute adrenal crisis, hypovolemia, which is not responding very well to fluids, and she has hypothyroidism, most commonly autoimmune. Yes, sir, quick comment. Yes, excellent. So this is a classical case of APS2. So she has hypothyroidism, vitiligo, and hyperpigmentation. So what to do next? Do we wait for her cortisol value or do an ACTH stimulation? In an acute scenario, no. We just draw the samples for cortisol and ACTH and we start her on hydrocortisone replacement with a provisional diagnosis, as Sir said, of APS2. So IV hydrocortisone was started, saline was continued, and in the next 2 hours, she started to improve. So acute adrenal crisis is an acute health impairment which comes with hypotension, dyselectrolytemia, acute abdominal symptomatology, and the metabolic disturbances may also have altered sensorium, and they respond very well to parenteral glucocorticoids. Now, in an acute scenario, if the cortisol is very low, it might be itself enough to make a diagnosis of acute adrenal insufficiency. And these are some of the diagnostic features we should be, on the lookout for, but there are no defining diagnostic criteria. It is by and large a clinical diagnosis. And always look for triggering factors like infection, surgery, pain, etc., which could have triggered adrenal insufficiency. So management would entail hydration with crystalloids. So isotonic saline would be the best to administer, and monitor vitals, BP, electrolytes. The drug of choice in adrenal insufficiency is, in the acute setting, is hydrocortisone. And you give 100 milligram bolus, and then you give 200 milligrams over the next 24 hours, gradually taper. As the patient improves, we can switch to oral therapy. Dexamethasone in this scenario should be preferably avoided, and we also treat the precipitating factor, whatever it comes out to be. One important factor is that in patients with primary adrenal insufficiency, simultaneously, we should also be starting mineralocorticoids, because they will be more important from the maintenance of the fluid electrolyte balance. But mineralocorticoids can be delayed till your hydrocortisone dose is still 50 milligrams a day. It has significant mineralocorticoid action of its own. Coming to the case scenario, so with this treatment, the patient became conscious by the next morning and she was accepting orally, electrolytes, renal parameters, everything had improved. Her reports came in as cortisol very low, 1.5 microgram per dl, ACTH very high. Again, reconfirming what we were suspecting. The CT did not show any mass lesions, where we were thinking of ruling out other causes like tuberculosis or fungal infections, etc. And by day 3, she was now in the transition to maintenance therapy. So what are the next steps? We confirm the diagnosis. In this case, by and large, we've done that. Determine the cause, give maintenance therapy, educate, and empower. Now, looking at diagnosis, if you have an acutely ill patient with a basal cortisol of less than 5, that does suggest adrenal insufficiency. Less than 3 is very strongly suggestive. You may even skip the confirmation test. More than 10 is unlikely, but not completely unlikely. So if you have still an index of suspicion, you want to do the next tests. In primary adrenal insufficiency, ACTH levels are usually above 100 picograms per ml, and in secondary or tertiary, they may be normal or very low. So what do we do for confirmation is the ACTH stimulation test, and what we use is ACTH 1 to 24, that is tetracosectide, given intravenous or intramuscular 250 micrograms, and a cortisol sample is taken at 30 or 60 minutes. A value of less than 18 is confirmatory of adrenal insufficiency. What if we don't have this tetracosectide and we really had a short supply of this? We do have studies from several parts of India where porcine ACTH has been used, actin prolongatum, and the dose for porcine ACTH is 20 to 30 units to be given intramuscular. It is not to be given intravenous, only route is intramuscular, 20 to 30 units. And you can use it as a substitute for the tetracosectide. There is some role of doing low dose ACTH stimulation test and insulin tolerance test in certain cases of secondary or tertiary adrenal insufficiency, but we'll not go into those. Other thing that we should do when we are suspecting primary adrenal insufficiency is also measure plasma renin and aldosterone. A high renin with a normal or low aldosterone suggests that we also have mineralocorticoid deficit. Even if you're not seeing hyperkalemia or hyponatremia, it will be a good idea to do this. So once we've confirmed abnormal cortisol secretion and looked at whether it is high ACTH primary or low or normal ACTH secondary adrenal insufficiency, we want to determine what caused it. If you have a clear-cut history of autoimmune disease like in our patient, you can assume that there is autoimmune disease, then screen for other autoimmune conditions. But otherwise, definitely do a CT scan of the adrenals for infiltrative, infective, hemorrhagic, and other causes. For when you're suspecting secondary adrenal insufficiency, there are two important next steps. One is MRI of the sella and hypothalamus to rule out structural lesions in that area. So if there's a tumor infiltration, that would show up. And the other important thing to do is measure anterior pituitary hormones, because a person who has deficiency of one HP axis can also have deficiencies of other axes. We'll briefly talk about this. So chronic treatment in adrenal insufficiency primarily rests on glucocorticoids, and if it's primary, it also rests on mineralocorticoids. There is some questionable role of adrenal androgens. Replacement therapy is lifelong, and very important is the need for stress dosing. Now we have so many of glucocorticoid preparations, which one to use? There are structural changes in steroid nucleus and side chains in all of these, which determine what their PK/PD profiles would be. So hydrocortisone traditionally is a short-acting glucocorticoid. Then we have prednisolone, which is a medium-acting or intermediate-acting glucocorticoid, and dexamethasone, betamethasone, or deflazacort are long-acting glucocorticoids. Now, in this case, we want to mimic physiology, so we want to prefer a short-acting glucocorticoid. And what we want to do when we replace any hormone, we want to try and mimic the endogenous rhythm of that hormone. So what is the rhythm for cortisol here? Cortisol secretion rises in the early morning hours before a person wakes up. It reaches a peak at awakening, and then there is a gradual decline during the day. So evening levels keep falling low with a nadir at around midnight, and then after midnight again there is a slow increase in cortisol secretion. So this is what we are trying to mimic, and that's why I said long-acting glucocorticoids should not be used. A drug which already has a duration of action of 36 to 72 hours will give us a constant high level of cortisol throughout the day. So the drug of choice would be hydrocortisone preferably, but if we don't have that, as was in short supply during the pandemic, the next best alternative would be to use prednisolone in the morning. Now, traditionally speaking, the glucocorticoid replacement doses have been recommended for hydrocortisone of 15 to 25 milligrams per day. but these are actually very high. Why I'm saying that is that if you look at the glucocorticoid production rate of normal person, it's 6 to 8 milligrams per meter square per day. So when we give it per kg body weight or per meter square body surface area, the actual dose requirements in various studies have shown to be much less, 10 to 12.5 milligrams per day of hydrocortisone for an average adult. So how do we give that? We use it in divided doses. So 2-dose regimen, we can give first dose on awakening when the peak is happening and second dose in late afternoon. So this would be the timing. Or a 3-dose regimen, wherein the first dose is in awakening, second dose in early afternoon, and a third much lower dose in the evening, 4 to 6 hours before bedtime. If we are to use prednisolone, the ideal way would be to use 3 to 5 milligrams once daily in the morning. And mind you, actual doses have shown to be much less. The dose requirements have shown to be much less than what was recommended in 2016 by Endocrine Society. How to monitor therapy? Now, when we are monitoring thyroid replacement, what we're doing is we're using a biochemical measure of TSH, but unfortunately for glucocorticoid replacement, biochemical monitoring has not been shown to be accurate or adequate. So there is no role of cortisol, ACTH, or urinary free cortisol measurements. In fact, studies have shown that if we try to chase ACTH, we overtreat the patient. So what we need to look for is symptomatic improvement and any signs of overtreatment. So look for anorexia, weight loss, vomiting, fatigue, persistent or increasing pigmentation, which would suggest that we are still under-treating the patient. We might have to increase the dose, try increasing by maybe only 2.5 milligrams of hydrocortisone and see how it happens. But also be watchful for signs of over-treatment, and those signs would be weight gain, hypertension, glucose intolerance, disturbed sleep patterns, and decrease in BMD. So always watch for those signs. Another important thing to remember is when we teach our patients, we have to teach them also about stress dosing. There are 2 modified release hydrocortisone preparations that are not yet available in India but have been used in some European countries. So one is a dual release preparation which can be given in the morning once daily. So it mimics the early morning rise and then the evening low. It has shown some advantages in terms of less risk of over replacement, and the same was with Chronocort, which is a sustained release preparation. Again, it showed less risk of side effects, but they're not available. The second element we were talking about is mineralocorticoid replacement therapy, which is needed in primary adrenal insufficiency. Standard doses are 50 to 100 micrograms. It is also important to tell patients not to restrict salt and water intake, especially in summer, this kind of weather. Inadequate replacement can lead to recurrent adrenal crisis, and it can also mean that we compensate the low doses of fludrocortisone by high doses of glucocorticoids. So try and optimize this. And fortunately here we do have biochemical monitoring. Try to keep the electrolytes in the normal range and try to keep the plasma renin in the upper limit of normal. Another important thing is during intense exercise and in very hot humid climates, we should tell our patients to slightly increase the dose. What if a patient develops new onset hypertension while on fludrocortisone? The dose should be slightly cut down by 50 micrograms. If it's on 100, bring it down to 50. But mind you, never stop fludrocortisone. If the patient requires, start an anti-hypertensive agent, preferably a RAS blocker or CCB, but avoid using diuretics. DHEA replacement, there have been some studies in women, premenopausal women, that it might lead to improvement in quality of life, improvement in libido and sex drive. So it can be offered to some women who have persistent reduced well-being and female sexual dysfunction, even after glucocorticoid and mineralocorticoid replacement therapy. But give a trial only of 6 months, 25 to 50 milligrams of DHEA, and if the symptoms don't improve, it should be discontinued because we don't have long-term data on its safety and efficacy. What are the long-term risks to watch for? Look for, because these patients may be overtreated with glucocorticoids. The risk of infections has been found to be higher, so be watchful of that. Weight gain, adiposity, hypertension, diabetes, dyslipidemia, all of these we have to watch for. We have to look for increased cardiovascular risk and treat them as per standard CV risk parameters. Another important monitoring they will require is for osteoporosis. So patients on long-term glucocorticoid, even if it's replacement therapy, it would be a good idea to monitor the fracture risk in osteoporosis. The most important part which we should educate the patients is about the sick day rules. Unfortunately, there are only 2 sick day rules, sick day rule 1 and 2. So in case there is an illness or fever and the patient has or is undergoing a small procedure like a dental procedure, they should double or triple the dose of glucocorticoids for 2 to 3 days, and they should increase their fluid intake. Sick day rule 2 is if there is prolonged vomiting or diarrhea or any more severe acute illness, then they should be given intravenous or intramuscular hydrocortisone. We should teach them how to inject it preferably, and they should also carry a few things. They should always have enough supply of hydrocortisone and fludrocortisone at their disposal so that they don't land into an adrenal crisis. If there is an acute sick day rule needed, they should be able to double the doses. Leaflets about stress dosing they should have. They should have a medical alert card which can alert the treating emergency resident or physician or intern that this patient has adrenal insufficiency in the backdrop and an emergency injection kit. So in the last 1 minute, let me take you quickly through 2 very interesting cases. A 65-year male, lightheadedness, giddiness since 2 weeks, had loss of weight, appetite, and fatigue, malaise since 2 months, who had diabetes well controlled but now having recurrent hypoglycemia. If you look at electrolytes, labs, everything looks normal, BP slightly on the lower side. And when we did the hormonal profile for this patient, just because of the suspicion of recurrent hypoglycemia, patient had low T4 with a normal TSH, borderline low cortisol. So we went ahead with an ACTH stimulation test which confirmed adrenal insufficiency. Patient also had low testosterone and a normal prolactin. So what we had is a non-functional pituitary adenoma with adrenal insufficiency, hypothyroidism, hypogonadism. The message here that I want to give to you is always start replacing steroids before replacing thyroid. Last case scenario was a 51-year lady, weight gain, generalized swelling, aches and pains since few years. She'd been using betamethasone off and on and was advised to stop it abruptly 1 month back. And what is the question here? The question here is, do we keep her off glucocorticoids? She does have some Cushingoid features. So any patient who has glucocorticoid-induced Cushingoid habitus should be suspected to have adrenal insufficiency, and we should put them on a maintenance dose of prednisolone or hydrocortisone, gradually taper those down before stopping it. So the key message is, whenever you suspect adrenal insufficiency, even think about AI, always consider ruling it because features are non-specific. Try and use near physiological replacement doses for hydrocortisone or prednisolone, and always supplement patients with primary adrenal insufficiency with mineralocorticoids also. Teach about stress doses. Prevention of adrenal crisis is the most important thing to do. I'll conclude here and thank you for your patient listening.
Thank you, Dr. Gagan, Priya, for the nice discourse. She has covered every aspect of the problem.